Alrighty, well, my name is Mary Ann Dowd, the president of the Down Syndrome Network of Montgomery County. And I am thrilled to welcome Dr. George Capone, the director of the Down Syndrome Clinic and Research Center at Kennedy Krieger, and Brent Gillero is the Research and Medical Senior Director at the Global Down Syndrome Foundation. And they have a presentation they're going to share with us tonight about global medical care guidelines for adults with Down syndrome. Thank you so much for coming today.
All right. Well, thank you so much for that introduction. We are thrilled to be here. Welcome to the Global Medical Care Guidelines for Adults with Down Syndrome webinar today. My name is Bryn Gillero, and I am really honored to be co-presenting with lead author on this, Dr. George Capone. And I'm extra excited because I grew up in Howard County, so very close by to Montgomery County. So welcome. First, we'll just go over what we're going to present today and kind of the order. I do have to apologize. I am on parental leave. I have a 7-week-old infant. So if at any time anything I'm saying doesn't make sense, please ask me to clarify, put a note in the chat box. I have less sleep than usual. Brief overview of our session today. I will go ahead and share an overview of Global's role in the guidelines, how our mission and how we came to work on this important project, as well as some background on the structure of the guidelines, what's included in the guidelines, how they came to be put together and that process. And then I will hand it over to Dr. Capone, who will share a bit more about the in-depth topics. And, it's a lot of information. And so I want to let you all know right now, we will be sending a PDF of the slides out afterwards. Please enter any questions you have in the chat, and we will do our best at the end to get to those questions. And that's really, just quick disclaimer. I mean, not so quick disclaimer. I'm not a doctor. And of course, we don't know your specific loved one with Down syndrome. And so as we mentioned, we will do our best to answer the questions at the end, but we cannot provide any specific medical advice. And we are happy to share the link with the guidelines and the PDF at the end of the presentation with you all. So with all of Global's PowerPoints, we like to begin with the inspiration behind our work, really being our wonderful CEO and president, Michelle C. Whitten, has a fabulous 18-year-old now with Down syndrome, and her family really led the way in starting Global after Sophia was born 18 years ago. And the inspiration for Global was really twofold. When Michelle was pregnant with Sophia and received a prenatal diagnosis of Down syndrome, she learned two things. One, people with Down syndrome have what we call a different disease spectrum, meaning that they are really predisposed and have an increased likelihood of developing certain conditions when compared to without Down syndrome. Some of those things you may be very familiar with, like Alzheimer's disease or autoimmune conditions. And then they seem to be protected from, or at least have much lower rates of other conditions compared to the general population, things like cancer or heart disease. And of course, that's really interesting, but because it would seem to suggest that they would need unique medical care. And despite this difference, there was also a life-threatening disparity in funding, in NIH research funding. At the time in early 2000s, Down syndrome was the least funded genetic condition by the NIH. And so Global was really formed to launch to advocate for research and medical care to improve the lives of people with Down syndrome. And to date, we are an affiliate network of 5 organizations working together to improve the lives of people with Down syndrome, working on research, medical care, advocacy, and education. We have over 2,000 unique patients at our C-Center pediatric in Colorado, as well as an adult clinic. And I'll briefly mention some of our lobbying and advocacy work, as well as some of our research in the next few slides. And again, it's a lot of information. I'm just going to do a little brief overview. And when you get the slides, you can really read it closer and dig in. To date, in 2017, Global successfully organized the first congressional hearing on Down syndrome research funding, and we succeeded in tripling the NIH budget for Down syndrome, which was incredible. And many of you are familiar with Frank Stevens' testimony before Congress, which went viral, as it should have. And to date, we've gone from $27 million in 2016 to over $118 million estimated for this year. So we are now working on not only just continuing to advocate for sustained growth, but continuing that growth. And so that's huge. And that means more research funding means more grants available for better research and translating to better medical care. Our research affiliates, Linda Cernick Institute for Down Syndrome. When we started Global, there was one scientist on the CU Anschutz campus working on Down syndrome research, and now there's over 200 scientists working on Down syndrome research. We've had incredible breakthroughs on the immune system related to the interferon pathway, and our Human Trisome project. Again, all the details are here, and you can read them for yourself, but it basically a major discovery related to the interferon pathways in JAK inhibitors, which allowed Down syndrome to be categorized as an immune condition, which is incredibly interesting, and also led to additional trials. Here we have some of our first NIH-funded trial for autoimmune skin conditions. And our Alzheimer's and Cognition Center also just received funding for the first leukine drug trial in Down syndrome. So I encourage you all to look at both of these flyers for some of our research projects, and let us know if you're interested in learning more. And now, without further ado, we will jump into the global guidelines, the reason we're all here today. And we like to think of the guidelines as an important legacy project for our community, not just because we are committed to creating a legacy of health for every current adult with Down syndrome and every child that will grow up to be an adult with Down syndrome, but it's a legacy project because we are committed to continuing the work. Guidelines are not static one-time endeavors. They have to be continually updated in order to stay relevant. And so that is Global's commitment to this work, is updating them every 5 years to add to the topics that were already published on in 2020 in the first version, to incorporate any new research we learn in between publications, and to add new topics to that. So this is really, we think of it as a treadmill. We're on the treadmill and we're not getting off. There was a critical and timely need for the guidelines. We have an increased live birth rate for infants with Down syndrome, as well as people with Down syndrome living longer. And longer is wonderful, but it's only part of the equation. We need that lifespan to be coupled with better medical care into the 50s and 60s in order to increase that lifespan and help them age in a healthy manner. And so, the increase in NIH funding, due in large part to Global's advocacy, has, it fits perfectly with the timelines. We need more research. We need to address these key research questions so we can have even stronger guidelines. Some of you who have been with Global and seen us speak on the guidelines at other conferences and events may know that we've been working on them for, by the time they were published, we've been working on them for 6 years, 5 years of work, 6 years of kind of getting all the pieces together. And Global really took on the guidelines because the community said, based on some of our focus groups, they said, we need medical clinics, but we'll never be able to get enough clinics across the US fast enough. And so how can we address that? The community said, we want guidelines. We want guidelines so that our general providers who see most of our adults with Down syndrome have some insight onto their unique needs and how to address them. And so part of the challenges and why this took so long, not just the lack of funding, which makes research difficult and also slower, is that there were only 12 adult focused clinics across the US, which means that there are very few experts in adult care. And we like to think we are lucky enough to have many of them on our author committee. And of course, Down syndrome is a single system condition. And so any address Down syndrome would have to address every single body system, every single condition. And so that takes time. That's part of the reason why we feel like this first version of the guidelines is really just the starting point. And then, of course, it just takes a lot of time and financial backing and support as well to create the guidelines. So that's why we think of this is kind of that legacy project. It's continuing, it's a living project. And we wanted the best experts, and we feel like we have on our author committee. Here you'll see many of the Down syndrome experts you are familiar with, as in addition to Dr. Capone in your own backyard. And we are very fortunate that this represents many of the adult clinics across the US. And then after we recruited the authors, they were tasked with forming volunteer committees to help with the recommendations, with reviewing the literature that we did find. And I won't go through all these names, but something to be aware of is that many of the individuals here who supported the authors, some of them were Down syndrome experts, and then some of them were experts in specific topic areas. And that was, of course, because we wanted people who not only knew Down syndrome, but then people who were experts in things like autoimmune conditions. And so together their knowledge could support each other to make the best guideline with the knowledge and research possible. And of course, part of these being the first evidence-based guidelines for adults with Down syndrome require that they met certain standards that are more advanced than, say, opinion pieces or guidelines that are maybe based on clinical experience alone. And so we went through these two processes called, forming PCOT questions, which and this grade evidence decision-making format. And basically, these just mean that it allows in future versions of the guidelines, other authors can go back and look at what we did. It creates a really transparent process for additional topics, for additional research. It also shows other authors, it shows other clinicians who read the guidelines that we were following gold standard processes, and it makes them trustworthy and the highest quality. And what this does do, though, in conforming to that quality, that highest quality, it means that we had to look at only the best research available. And so you'll see as Dr. Capone goes through some of the recommendation statements, he'll talk about things like strength for the recommendations statements, that there were things that were weak recommendation statements versus strong recommendation statements. And what that means is really, it doesn't mean that you should follow the recommendation statement more or less. What that really refers to is that there was a weak evidence base to support the recommendation. So we had maybe only a few very low quality research pieces, and that the strong recommendation statements, we had really great, robust evidence backing up that recommendation statement. But they should both still be followed. It's just, again, to let readers know and clinicians exactly what kind of evidence and research we're working with when the authors make those statements. And then, of course, something else that took a lot of time, we love to do focus groups, family focus groups for everything that we do. And so the guidelines actually went through a full family and self-advocate focus group with almost 40 individuals across 10 different states. Many local Down syndrome organizations helped us recruit those individuals. And so those results are also published in the guideline itself to kind of show how families and self-advocates found the guidelines, what they thought of them. And then the authors actually got together, reviewed every single comment individually, and made edits based on that feedback. So just something to keep in mind, that these were not only requested by family members and self-advocates in our community, but they were reviewed by our community as well. And we have continued that promise throughout this process. All of the toolkits, all of the upcoming new exciting pieces of the guideline that I'll speak on more at the end, they are all going through family and self-advocate focus group review. And the authors did take that into account and made edits. And so if you're ever interested in becoming part of these focus groups or want to be involved, please do reach out. We would love to put your name on a list and send you an email when we have focus group opportunities. And then the results, all of that was done in that 4-year time process. And the results were really coming up. We came up with 40 topics the authors had to narrow down to their initial 9 guideline topics. And so those 40 topics were really, everything they could think of that would impact the health of a person with Down syndrome. And based on their experience, they had to start somewhere. It was an incredibly difficult process to narrow down from those 40 to these 9. But here are the final 9 that are represented in the guideline currently, with other important topics like sleep apnea and cancer. We're already looking at for the future for the next update to be published in probably 2025, 2026. It's really just hard to imagine the amount of work and money that it took to get to this point. But Dr. Capone can speak to that more, how we came to these topics and why. And we look forward to adding on to them. When we talk about the lack of evidence and research there were even for those 9 topics, I think just to give you a little idea of the real lack of research, when we started this process, there were over 11,000 articles that they found that mentioned Down syndrome, that included people with Down syndrome in these 9 topic areas. And by the time that we sorted them through our kind of rigorous research process, only 22 studies qualified as being quality enough to use them to write our recommendation and to create the guidelines. So that, again, just really underscores the need for more research, and that increase in the NIH funding, we hope, will support that research. And so what the result in the guideline, it resulted in 4 what we call statements of good practice. And these are maybe, these are not recommendation statements per se. Statements of good practice are based more on either clinical experience, or maybe it seems a bit obvious to state on a health practice, but we want to underscore that it should not be overlooked in a person with Down syndrome. I think we'll get an idea of what we mean as Dr. Capone goes more into detail in those 4 statements of good practice. And then we have 14 recommendation statements. And so we will go through those here in just a moment. And of the questions that we asked, 14 of our questions had no research, no evidence available. Of our 26 questions, 14 had no evidence. And what this means, again, is we need more research. It means that the bulk of our recommendation statements in this first guideline are considered maybe they're weak recommendation statements, meaning the research available for them was weak. It doesn't mean that you should follow the recommendations any less. And in those cases where we had no evidence, we relied on the experts, on our incredible author experts. So that is why it was so important that we had providers that have seen thousands, cumulatively thousands of people with Down syndrome in their practices. And then, of course, we worked incredibly hard and diligently over those years, and we succeeded in having the article published in JAMA. And it's a really big deal because JAMA is seen as very prestigious and trusted in the medical community. And that's what's really important, right? Is we want providers, practitioners across the US to look at this and say, wow, we really need to take the health of adults with Down syndrome seriously. And maybe I feel a little bit more confident at how to do that. And so this was a real success. This first version is written for medical doctors. Those of you who have looked at it, it is really dense. The language is dense, the terminology is dense. And we are working now and soon to be published a family-friendly version. And so more on that later. But the guidelines were published in 2020, and we are currently already looking at the next parts of the project. And so without further ado, I will hand it over to Dr. Capone, who will share more on the 9 topic areas that we covered. Dr. Capone, you can.
Yeah, well, thanks, Bren, and thank you for inviting me to be a part of this presentation. It's very exciting to have some published guidelines out there to be able to share with families and primary care doctors in the adult sector. As many parents have come to learn, the training for neurodevelopmental disabilities in adult medicine is not the same as what it is in pediatric medicine. And so when you make the switch from a pediatrician to an internist or a family practitioner, there's often a gap in their understanding, essentially, of the needs of people with Down syndrome. So in addition to giving them the American Academy of Pediatrics guidelines, we now have adult-specific guidelines. And you can see the topic areas here before you. I'm not going to read each of these from this dense table, but this is what we'll be discussing. Next slide. And yeah, so 14 recommendations and 4 statements of good practice. So let's just go through them and we'll take questions at the end. So first is a statement of good practice regarding behavior. And we recommended review of behavior, functional activity, and psychosocial activity as part of an annual history. So that's to point to the obvious that physicians should spend some time exploring these areas in their discussion with family and the person on an annual basis. Second statement, when a concern for a mental health disorder is present, we recommend that you, the primary care physician, start to evaluate for medical conditions that could be contributing to this. There is an intense relationship between medical, mental health, and behavior. And some of these are well known to families and parents, others are not so well known. I mean, I'll just mention sleep apnea and sleep problems as one big area. Hyper or hypothyroid as another area. Okay, next slide. So here are some actual recommendations that were based on a very limited evidence base, but nonetheless, we thought that they were warranted. When concern for a mental health disorder is present and the primary has ruled out something like hypothyroidism or untreated sleep apnea, then we think it's worth referring to a clinic or a clinician who is familiar with these conditions in people with Down syndrome. So it's basically saying if you feel like you're not figuring it out on your own, refer to another resource. Of course, how many of these clinics do we have around the country? How many people do we have who are able to see our adult patients? Well, that's a related but separate conversation. The other recommendation is when diagnosing a mental health disorder, follow the same guidelines you would in the general population. There are some adaptations that are made for mild to moderate intellectual disability. And so the DSM guidebook has been amended into the DMID. And so that is what's recommended. Next slide. In terms of dementia, this is like the ghost that's in everybody's bedroom, comes out at certain times during the night or even during the daytime, and this is something you can't stop thinking about in some occasions. But it's really true that prior to the age of 40, although the biological process may be underway, I think research has shown that that's true. The biologic process is underway. We're not really seeing clinical symptoms of dementia, or at least age-related Alzheimer dementia. We're not seeing that in people under 40. We're typically seeing that in people over 45 and usually over 50. And as you progress through your 50s and into your 60s, you know, the incidence goes up. So it is an age-related risk for sure. And we think the connection is that at least one of the genes for the Alzheimer protein, the amyloid protein, is linked to chromosome 21 and expressed in an extra copy. Next slide. So be cautious when diagnosing under 40. That was made it into the recommendation because it was, the evidence actually supported that, and that was quite a good recommendation. Next. And we recommend that starting at age 40, that the primary care docs start to take baseline data about memory, executive functioning, behavior, personality, communication, their ability to ambulate and get around, and just their general ability to do things for themselves independently or with the same level of support that they've always required. So it's important to get people on board monitoring these areas. Just like we said, every year a behavior inquiry should take place where you ask about changes in psychosocial stressors, changes in behavior. We're doing essentially the same thing here, but targeted towards dementia over the age of 40. Next slide. Diabetes, okay. So adults with Down syndrome have two factors that contribute to diabetes. One, there's an autoimmune component to diabetes, which shows up as a type 1 or insulin dependent diabetes. Then there's this prevalence of obesity that we see in adolescents and adults, which contributes to the prevalence of type 2 diabetes. And so we recommend that beginning, and again, these are only adult guidelines, that if you're already obese at age 21, that you be screened every 2 to 3 years minimum using this hemoglobin A1C or fasting blood sugar. If you're not obese, you can delay the screening until a later time, say over the age of 30. But because many of our individuals struggle with weight management, and it's a question that, again, you can't kind of forget that it's there. I'd say most docs are pretty good about checking fasting blood sugar and hemoglobin A1C in people who are overweight or obese. Now, we're not sure if early detection and management delays any of the complications that are seen in long-term diabetes. In fact, we don't even know if those same complications are present in people with Down syndrome. We just don't have enough long-term data and outcome data to say. So for instance, people who have poorly controlled diabetes may have renal failure. They may have problems with vision and retina and things like that. Next slide. Cardiovascular disease. So this refers to like atherosclerosis and stroke. And for adults without a history of atherosclerosis, we recommend that you not jump into the use of cholesterol lowering medicines, at least until the age of 40. And the reason for that is that the benefit of statins plays out over a very, very, very long time. And if you don't have the criteria like a certain threshold of cholesterol or triglyceride that's being met, then there's actually a little bit more risk to being on the medicine than to not being on the medicine. So the risk of the side effect is greater than the risk of any outcome being atherosclerosis or myocardial infarction. And so this is something that adult docs know how to calculate. There's a risk calculator that's part of the electronic medical record. And they have access to that for all their patients. So it's in play in the same way as it is for the rest of the population. Next slide. For stroke, it's a similar story. Although the risk for atherosclerotic disease is lower, the risk for stroke may be a little bit higher. And that may have to do with either uncorrected septal defects in the heart, although certainly the vast majority are well corrected and permanently corrected. Sometimes there's problems with the leaflets of the valve that can set you up for an embolic stroke. So I think that's where the increased risk for stroke comes from. It's usually not the bleeding type of stroke where you have a hemorrhage. It's more this embolic stroke, which can be seen due to cardiac defects. Next slide. Let's talk about obesity. So we know that body mass index is increased. We know that it's increased partly because people with Down syndrome are shorter, and body mass index is a measure of proportionality. It's your weight for a given height. And because people are shorter, it doesn't take much weight gain to become disproportionate, so to speak. So approximately 65 to 70% of our adults are in that overweight or obese category. And that's research that's held up pretty well over several decades. It's been looked at more recently. So it's not that it's old data. And we know that obesity has consequences, right? It's associated with other physical problems, mental health problems, and social issues, self-esteem and that sort of thing. Next slide. So as a statement of good practice, we recommend a healthy diet, regular exercise, and calorie management for all adults. And that being able to monitor or oversee things like portion and meal size turn out to be very important for some people. It sounds like you're going against the desire to have people be independent agents for their own well-being. Really, I think we should see it more as coaching. You're kind of coaching from the sidelines. Now, I know these coaching suggestions are not always welcome by the individual, so there has to be some way to do this without precipitating too much of the fallout. Yeah, next slide. So a recommendation is to monitor weight change annually, which is something that happens in most doctors' offices. The BMI is computed automatically when height and weight are taken. And, the same behavior weight loss interventions should be available to our group as they are to the general population. So in terms of medical, that might mean making sure thyroid disease is not present, making sure untreated sleep apnea is not present, making sure that you are able to control portion size or cut down on carbohydrates and sugar-containing beverages, but that in extreme cases, there are weight loss medicines, and that should be made available as well. So that the healthy eating practices include good hydration, limiting, as I said, sugar-containing foods and portion size. And then equally important is physical activity It's gotta be fun and it's gotta be social, or it just may not happen on a regular basis. It's the rare individual who will get on the bicycle or the track every day, even when it's as convenient as down the hallway or in their room. So dance and karaoke and Zumba and those kinds of things make it more fun. Next. Okay, in terms of osteoporosis, so this refers to bone density and bone strength. So there are some studies out there that show there's a higher risk of low bone density in adults with Down syndrome when you study it using the DEXA scan. But do we see the same consequences? Are we seeing more fragility fractures, which means when people trip and fall, they're more likely to break a bone, the hip, the ankle, the femur, something like that? And can the same medicines that are used to treat the general population be useful for people with Down syndrome? So these are related questions that we don't have full evidence on. Next slide. What we're saying as a recommendation is that if someone does sustain a fragility fracture, so they trip, they fall, they break their ankle, they break their femur, then not only should that be treated as an acute fracture, but they should have a DEXA scan to evaluate bone density. Because why should someone be predisposed to a fracture at a say when they're in their 30s or early 40s? Well, because sometimes in people with Down syndrome, you do find osteoporosis. Sometimes they have celiac disease and they have poor vitamin D absorption, or they have hyperthyroidism, or they have hyperparathyroidism, or some of the medications that interfere with bone density. Like I think you'll read these warnings on a lot of the medicines that are used for gastroesophageal reflux. So, everything has to be taken into consideration. It doesn't mean you shouldn't use medicines for GE reflux if absolutely needed. It may just mean you need to be taking vitamin D and calcium as well. So you always need to look at the overall picture. Next slide. Okay, there was a question earlier in the chat. What is AAI? Well, this is AAI. It's atlantoaxial instability, okay, or C1, C2 subluxation. Now, this is something we used to talk about a great deal in children. And in the American Academy of Pediatrics, they address this. And many of you who now have adult children know that 20 years ago, we recommended routine screening for atlantoaxial instability by age 3 or 4. And then on top of that, Special Olympics would want it to be done. Horseback riding programs would want it to be done prior to participation. But now the recommendation for children, at least, is to only do it if symptoms are present. What does that translate for into adults? Well, it's the same kind of logic. If you're not having symptoms, and those symptoms would be inability to flex or extend the neck, having the neck or head rotated and stuck in a position that you can't get out of, or having very rapid and brisk reflexes in your lower extremity, or inability to walk in someone who was previously able to walk. Those are signs that you may have symptoms and that you should get a neck X-ray. But in the routine examination for adults, you don't need to get a neck X-ray. You just need to do a good neurologic survey and make sure that the person has good rotation and flexibility at the head and neck joint. Next slide. For hypothyroidism, well, just as in children, we know that hypothyroidism is pretty common. And by the time you're an adult over the age of 30, it may be as high as 50%. So continue to check thyroid function every 1 to 2 years. In children, we check it every year, but for adults, we needed a justification for saying every year. So I think we hedged a little bit and said 1 to 2 years. Next slide. Yeah, so we left it open to interpretation, 1 to 2 years. As far as celiac disease, which many of you know about, oh, excuse me a minute, I need to cough. Okay, for celiac disease, we recommend using a targeted history and physical exam that's based on GI symptoms. There are also some non-GI symptoms to look for, particularly skin symptoms, and to focus in on these as part of your history and examination at the annual physical. Some of the consequences of celiac disease, as I hinted at earlier, would be vitamin D malabsorption. You can get B12 or iron malabsorption. So you can see things compound and play out over time that go beyond the celiac disease itself. Next slide. Okay,
All right,
so
George, I'm happy to jump in after.
yeah,
after
why
the
don't you
slide.
go ahead and jump in?
Okay.
I'll give my voice a little break.
Great, no problem. And so thank you, Dr. Capone, for the overview of the topic areas. And as he mentioned, that is, it's dense, it's a lot of content, but the good news is we have an exciting project coming up. I'll share more about that in two or three slides. We're almost done here. I mentioned that, Global is committed to keeping these updated and republishing them every 5 to 6 years. Since 2020, in October, not only did we publish the guideline, we published a one-page checklist similar to what the pediatric checklist offers, where all of the recommendation statements, all the statements of good practice are on one sheet. It's also a bit overwhelming to have all of that on one sheet. So we are currently working on breaking those down. So each topic, we're working on toolkits for each individual topic, as well as translations and more. So we have some of those individual toolkits. This is all available on our website. I will make sure everyone has the links. It is totally no cost to download. And then you can share those toolkits with your providers, with your self-advocates, review them, share that your local Down syndrome organization can link to them on their websites. And so I mentioned the translations. In the next month or 2 months, I expect we will have a finished version of the Spanish translation, as well as a Japanese translation with Italian on the way. I apologize, my cat is jumping in this frame here. Here we go. And so those are on the way, Spanish and Japanese. Within the next month or so, we should have that available, the full guideline. So look for that. We will be sharing them in our Global's e-newsletter. We'll be posting on our website. Also, and the thing about the translations that's been really fabulous is not only did we work with professional medical translation companies, but then we also have international advisory board for the guidelines, where we have partnered with a Down syndrome organization in country to then do an additional review of the professional medical translation to make sure that translations also meet kind of the cultural in language criteria that the Down syndrome organizations in country would expect for their families. So that's really exciting. And then some of the additional topics that we are hoping to already creating new questions on and looking towards the future, sleep apnea, solid tumor cancers, leukemias, and physical fitness. So these were not mentioned in the initial guideline and are incredibly important. And so we are looking at those now. And then coming soon, I mentioned we are families requested this in our focus group that we did for the initial guideline. The initial guideline is 80 pages long, a very medical dense text. We have this family-friendly global guideline that will be published within the next month or two. It is much shorter. I believe it's about 20 pages total, and only about 10 of those text. It's brief, it's to the point, our medical terms are defined. We used a really beautiful magazine kind of format layout. And so hopefully this will make the guidelines even more accessible to families, still includes all 9 topic areas. It's just clearer and really written with families in mind. And again, we put this through a review process. So we had extra support from the community to kind of share what made sense, what looked nice, what was useful for them. And then again, how can you help the global guideline in this process that we are committed to continuing? Please use the guideline, please use the checklist. You can bring them to your appointments, make sure your local Down syndrome organization has them on their website. So we'll definitely make sure that we send you the links to that and share it with your friends. And if you have any feedback, if you want to be a part of those focus groups, reach out. The info email on the screen here, I will check those. And if you would like to be a part of our focus groups in the future, we'd love to have you. And then just really, again, thank you. We're really proud and honored to be presenting to the Down Syndrome Network of Montgomery County. And we can, with that, we will do a quick look at the chat box for any questions. And as they come up, if we don't get to any of them, we have more time here. I think some of them were answered as we went. So thank you everyone for your help. Yes, AAI is Atlanta Axle Instability. So apologize, I had that abbreviation in there. The guidelines, someone asked, will they be published in Spanish? They have been published in Spanish. They are going through the final approval process as we speak. We expect in the next month or so that will be available. Let's see. Dr. Capone, here's a question. Are there any studies in issues around hunger center and hunger control in people with Down syndrome?
So yeah, thanks for that question. And this refers to a phenomenon that many parents are familiar with, that their child seems to be unsatiable in terms of their appetite and cannot tell when they've had enough to eat. So is there research being done on that? Well, I would say that it needs to be researched. Most of the research is so basic, looking at weight, looking at what are some of the risk factors for weight that are obvious, but the incidence of disordered eating and how you define that in a setting where food availability is also part of the equation, right? So you have to take into account the food that's available. But at the same time, I think there are studies that need to be done on the endocrinology and the feedback mechanisms for controlling appetite and hunger in people with Down syndrome. Some people just seem to not get that feedback message. Other people seem to overeat as more of an eating disorder that may be driven for other reasons. So I can't quote you any good studies. There's a message here that was sent to me. Should I go ahead and read it, Bryn?
Yeah, go for it.
So it just has to do with COVID vaccine. None of these talks would be complete without some mention of COVID. So is a 4th vaccine recommended for an individual with bicuspid aortic valve and Crohn's disease? Well, so assuming that individual got the initial 2 and the boost, I think that individual would be at slight increased risk for complications due to COVID because of the cardiac valve situation and because Crohn's disease, you get put on immunotherapy, immunosuppressant therapy. So that in itself can increase your risk for something like COVID. So I think the vaccine is probably very appropriate in an individual like that.
Great. Are there any Any additional questions, or George, anything that we failed to touch upon that we should go over again quickly?
Well, there's always lots we could say and lots
Right.
we could touch upon. Yeah, here's a good question. Is it possible for the families within your group to share knowledge about physicians who are willing to take their time and approach people with Down syndrome, in the best way possible? And actually, it is the parents and the parent groups that really have this knowledge, much more so than someone like me. I mean, I'm behind the walls of the tower, and I don't always see too far outside of where I am. I mean, that's not entirely true, but you know what I mean. I don't know the individuals in the communities all over Maryland. I'm not an adult physician myself, and so I don't interact with them in any way. And I'm not sure there is a unifying body that organizes them. But certainly parents through word of mouth or through a registry should be able to know who's a good doc out there willing to see your adult child. Usually someone with pediatric and medical training, or someone with family medical training, is a good choice.
And I will say that, Global also has, in addition to organizations like Dr. Capone, like with ISMEG, connected with other organizations like the American AADMD, and other organizations that may know of any of other providers. And so, again, don't be afraid to reach out to us, and we can connect. And families, if anyone has, we have found the most successful families who have done their own work to find those providers and then share those, and they become known in the community as the providers who enjoy and are willing to learn about people with Down syndrome. So you all have really paved that way for us to learn who those clinicians are. So we appreciate that.
There's a few more questions here.
Yeah.
Right.
Yep. So let's see. Let's start with what would you recommend to treat mental health in people with Down syndrome? Does counseling work? What medicines are used to treat mental health?
Well, so the whole gambit of mental health conditions can be seen in young adults with Down syndrome, just like in adults without Down syndrome. And so depending upon both the diagnosis and what the symptoms are that are actually present and interfering with quality of life and health, that's going to help make the decision on which medicines you would use, and also equally important, in which order to introduce the medicines. It's common that you need more than one medicine to touch on the variety of symptoms that are being manifested in our adults. But I think the order in which you approach it is important for reasons that have to do with individual presentations, we'll say. In terms of Down syndrome disintegrative disorder, this is a term. It sounds kind of harsh, doesn't it? Disintegrative disorder. It's kind of like an autistic regression seen in adulthood, and the person functions at a much lower level of their previous level of function, and they usually, but not always, have concerning behavior or mental health symptoms. Well, Down syndrome disintegrative disorder is one of these catch-all phrases. I don't know if it's helpful, more helpful or less helpful, because when you have someone who comes in with loss of function and disintegrative disorder, you need to look at major depression. You need to consider severe sleep apnea. You need to consider other mental health diagnoses. The Down syndrome disintegrative disorder term is most appropriately used when you've ruled out these other mental health conditions or sleep apnea or hypothyroidism or something, and you're left in this area where you're really struggling to find a cause. And so, yeah, we're interested in it. We're researching it. We're trying to educate our community about it and decide what are the best ways forward.
And I
Therefore-
will add to that, Dr. Capone, the traumatic experiences of trauma, trying into any past experiences of trauma. And we are, in formulating these guidelines, we did ask about specific mental health conditions and a regression as, Down syndrome disintegrative disorder, sometimes referred to as regression as well, was kind of specified in our questions, and there's just such little research. And part of that is there's a lack of a key criteria. There's lack of a single diagnosis. And so we are continuing to look at that. And we have wonderful experts like Dr. Brian Chicoine, who has done a lot of work on regression, as well as Dr. Lena Patel, who was also a guideline contributor and is doing work on regression, Down syndrome disintegrative disorder as well. So we're continuing to look into
Thanks.
that.
And I wanted to get back to one other point that Bryn brought up, and that is psychosocial stress or emotional trauma or physical trauma. A lot of what may precipitate these mental health changes could be the result of perceived emotional distress or true, real emotional and physical distress. Being bullied, being excluded, being made fun of. All these things can add up in the minds of an adolescent or young adult. And we do think that our population is more vulnerable, more susceptible to how that translates into something like what we would call at first an adjustment disorder. Somebody showing emotionality or moodiness as part of a grief reaction or an adjustment disorder to something that's changed in their life. But if it persists over a greater period of time, it may be classified as a depression or as a true anxiety or mood disorder. So these things are all related.
And then Dr. Capone, I did receive a direct message. Are there any recommendations to counter early dementia?
Well, the only recommendations that I'm aware of, and these play out in the general population as well, is to maintain physical activity and whatever degree of mental activity you can maintain. I think managing medical comorbidities like the obesity and maybe a type 2 diabetes is also going to turn out to be important, because we think that, carbohydrate metabolism and insulin play some role in Alzheimer's disease, even in the general population. It may cause the course of it to be accelerated or not. And we even think sleep problems can cause an accelerated course of Alzheimer's disease if not treated. But I understand that there's a lot of adults out there who aren't treated for sleep disorder because the thought is that they would never tolerate wearing a CPAP mask and may not even tolerate having a sleep study. So there's lots of problems to be solved out there for sure. But yeah, maintaining good health and maintaining activity. Hopefully very soon we are going to have some medicines that will be working directly on the amyloid protein.
And I mentioned earlier, one of Global's affiliate research organizations is working on the first ever Leukine trial in adults with Down syndrome. And so I'm also share the link when I send the PDF to this. And as Dr. Capone mentioned, if you are one of those families who does have such a difficult time with your adult, getting them to wear a CPAP machine, we've had some really wonderful presentations and webinars on our website on desensitization support to kind of help with that, or desensitization supports around sleep studies. So again, do reach out. Happy to share some of that information with you.
Okay. Can I answer that other question, Brent? It was directed for me.
Perfect. Okay. And then I see one. Okay. I think those are all the questions that I'm seeing here. There's a someone mentioned there's an adult. There's a Facebook group for parents of adults with Down syndrome with regression. So Lorena, if you want to share that, maybe with the organization members or with the executive director, then they can share that link more widely.
Mhm.
All right, and Marianne, is there anything else, any questions for us that you might have, or anything that we can?
I think the only point that wasn't touched on and is that mental health is so hard to access. Counselors in our area are few and far between. So if there's any recommendations you guys might have.
Yeah. Oh, that's, you're right. The question about does counseling work? Counseling can be very helpful for the right person, especially when there are these psychosocial stressors, or there's been some event or events that are having the person, be anxious or be in a low mood. So yeah, having counseling it can be helpful. Sometimes you also need the medicine to have the person, feel better as well, so that the counseling can be maximally effective. In the absence of an experienced counselor, I would get the book on mental wellness by Brian Chicoine and Dennis McGuire, and just present it, give it to a counselor who would agree to work with your individual. And giving them that book will be the best gift you can ever give them. And of course, one for yourself too. Many of you may already have this book. It's published by Woodbine. So yeah, that's a way to sort of build the network, if you will.
My background is social work. And so, in some of that, that practice, I'll just add that we've seen, and someone asked if we could write the name of the book. We will do that. It's called Mental Wellness with Down syndrome. That is the name of the book. Oh, sorry, I sent it as a direct message, but I'll resend it. Also, finding someone who is willing to try different modalities. So, if verbal communication isn't a strong suit, finding someone who's willing to do more kind of artistic therapy or play therapy, or even at the adult center in Chicago, where I did my master's undergraduate work or master's work, we were fortunate enough to have some group therapy. So having a few adults with Down syndrome who could get together and kind of process. So again, just someone who is willing to work and understand that communication and verbal communication may not be their strong, and that they're willing to be patient.
Right.
Yeah.
And I've seen a fair number of adults benefit from relaxation techniques. So you can teach them some simple relaxation techniques if you can teach them to recognize, say, that their anxiety is starting to build and get stronger. So kind of like at school, they have green light, yellow light, red light. Well, if there's some way to signal that in an adult and then have them kick in with their relaxation technique, that would be a good strategy.
Well, fantastic. Thank you so much for your time, Bryn and Dr. Capone. And I'm sure that people will want to have some follow-up with both of you guys. So we will have this presentation ready for anyone that wants it, and it'll be sent to participants tomorrow. Thank you so much for your time, everybody.
Okay, thanks, everyone.
Thank you and have a good night.
Yep.
Bye-bye.
Bye.